It's my pleasure now to introduce Dr. Ryan Jacobs, who is a hematologist oncologist at the Levine Cancer Institute in Atrium Health. At Levine Cancer Institute, he has been a clinician and the principal investigator in the lymphoma section. Dr. Jacobs has both a clinical and research focus in patients with chronic lymphocytic leukemia. In his role as a principal investigator, or PI, he oversees the clinical trials conducted at Levine and that involve the treatment of patients with chronic lymphocytic leukemia, or CLL. In addition to clinical trials, Dr. Jacobs has a research interest in real-world outcomes in patients with CLL, especially those on novel therapies. Please join me in welcoming Dr. Jacobs.
Hello, everyone. My name is Ryan Jacobs. I am in the lymphoma section at Levine Cancer Institute in Charlotte, North Carolina, and my research focus is in CLL. So my practice is enriched with CLL patients as the quote-unquote CLL expert for the Atrium Health system. And I'm here today to talk to you all about CLL initial diagnosis and a bit about the initial workup. And this will dovetail nicely into Dr. Hill's discussion about prognostic workup and frontline and beyond management of the disease. So here's the overall agenda. What I'm hoping you're able to leave this section of the day's presentation with is just a little bit of a better understanding of what exactly CLL is and some of the initial workup, the tests, imaging, etc., that we do, and hopefully you're able to leave with some of the myths, for lack of a better word, that surround CLL put to bed and have a more accurate understanding of what exactly CLL is. So without further ado, we will get going. Just a little bit of background about CLL. So of course, CLL, it's important to start with what exactly that stands for. CLL, chronic lymphocytic leukemia. So as I tell my patients, the majority of the time, the disease is going to present as both a lymphoma and a leukemia. So hence the two L's. You can see here in this picture, there is a nice diagram of all the different lymph nodes in the body. I would say for CLL, the patients might notice enlarged lymph nodes in the neck, above the clavicle, under the armpit, or in the groin. Of course, CT scans will pick up nodes throughout the body. It's almost always confined to the trunk and chest area. We don't typically see enlarged nodes out in the peripheral extremities, although they are there. The lymph nodes, of course, are where lymphocytes hang out, and we're of course talking about a lymphocytic leukemia. So lymphocytes can move in and out of the lymph nodes, and you can see the disease not only in the enlarged lymph nodes, but actually probably more commonly, CLL is noticed in the elevated lymphocyte count that can be detected on a simple blood draw. So what makes this actually cancer is in the bone marrow, which you see highlighted here. There is a monoclonal, meaning all the cells that look the same, process that are producing lymphocytes that all look the same, and producing too many of them. And they can show up in the bloodstream and show up in these lymph nodes with enlarged lymphadenopathy. And then sometimes, not pictured very well here, it's with this little small purple organ that's supposed to represent the spleen, which is kind of like a large lymph node that I tell my patients. And so like the lymph nodes that can get enlarged with these lymphocytes that all look, these cancerous lymphocytes that all look the same, so can the spleen. And the disease can move from one space to the next, and in and out of the bloodstream, in and out of the lymph nodes, in and out of the spleen, etc. So how do we make the diagnosis? Of course, we already defined what CLL stands for, but what exactly goes into making the diagnosis? So I mentioned that a healthy percentage of the time, patients actually get a surprise when they get some blood drawn and their white blood cell count is elevated. Perhaps the physician that drew the blood work tries to look at what element of the white blood cell count is elevated, and they will send a differential on that white blood cell count and find that the lymphocyte count is specifically what is elevated. And that's what in CLL I tell my patients to focus on, not so much the overall white blood count, but what is the absolute lymphocyte count, because the white blood count is made up of many different white blood cells. But of course, the cancer is the lymphocytes. So if the elevated lymphocyte count is either through a hematologist office, or sometimes a real savvy primary care physician will send this test. The blood, the peripheral blood, can be sent to what's called a flow cytometer, and that's just essentially just a machine that's in a pathology lab that can detect for these monoclonal cells. So normal cells aren't all supposed to look alike. They look different. Cancer is when you just get the same cell replicating over and over again, and not responding to signals to stop replicating, and overgrowth of these monoclonal cells manifests as a cancer. And so for CLL, we can detect the cancer in the blood with this flow test that looks for specific markers on the cell surface. And we'll talk a little bit more about this, but the markers that we look at for CLL is a CD5 or cellular domain 5 and CD23 marker. So co-expression of these, if you have this monoclonal population and the quantity of the lymphocytes exceeds 5,000, then that is sufficient for the diagnosis of CLL. And you do not actually have to do anything invasive beyond that specific blood draw to make the diagnosis. So here's some different cell surface markers that you can find on a B lymphocyte. You can see the CD5 and the CD23. That's going to be the ones that are the majority of the time co-expressed in CLL cells. So that it works about 85% of the time, but about 15% of the time, the lymphocyte count is actually normal, and all we get is enlarged lymph nodes. So lymphoma, of course, there's a lot of different kinds. The enlarged lymph nodes need an actual excisional or at least a core needle biopsy to make a diagnosis of a lymphoma. With CLL being both a leukemia and a lymphoma, because it's a lot easier to send a peripheral blood sample to the flow cytometer than to do an invasive biopsy, we tend to do that. But for SLL, or small lymphocytic lymphoma, this is what we call it when it's the disease is confined to the lymph nodes but not showing up in the peripheral blood, and we have to do a lymph node biopsy for this. It's an overlap disease, that's why you see CLL/SLL when we're talking about the diagnosis, and the treatments are the same, the approvals are the same, and sometimes a patient will start out as SLL and eventually develop circulating lymphocytosis, and then vice versa. Sometimes patients have the lymphocytosis but don't really have significant enlargement of their lymph nodes. What do we do after we get a diagnosis? So beyond the basics of just the general exam and talking to the patient and the basic blood work, we think about things like, does a patient need a bone marrow biopsy? And we'll talk a little bit more about that later. But does a patient always need a CT scan? And actually, that's not always necessary. We'll talk a little bit more about that later. We've already talked about flow cytometry to make the diagnosis. And then if patients are complaining of recurrent infections, we might check their overall quantitative immunoglobulins or IgG level to see if they have a specific deficiency in producing IgG. We might check infectious serology, is fairly routine in a new lymphoma diagnosis, to check a hepatitis panel and an HIV panel to see if there's a coexistent infection. Prognostic markers are going to be talked about in further detail by Dr. Hill, but here's a quick primer on that. In addition to the FISH and IGHV and the TP53 that you'll get very well educated on in a later presentation, we might also look at labs like LDH and beta-2 microglobulin, which serve as non-specific markers of cell turnover or replication. And when elevated, it might tip us off that the CLL is behaving a bit more aggressively if those values are significantly elevated. So back to that question on, does every patient need a scan? Well, it depends. Almost never do we need a PET scan. For patients, if we're concerned that maybe something more than just the CLL is happening, their disease is behaving very aggressively, particularly in the lymph nodes. Maybe they're having fevers and a lot of weight loss, and that LDH number is very high. We might be worried that there's a more aggressive lymphoma that's occurring, and that's called transformation, or specifically Richter's transformation. That's when a PET scan can be used to help differentiate between a low-grade and a high-grade lymphoma. But for CLL/SLL, just regular CAT scans are okay the large majority of the time. But actually, I typically do not order them unless I'm going to start treatment on a patient. And more about that decision about treatment, yes or no, later. But generally with initial diagnosis, unless I'm concerned about something I find on physical exam, or the patient has a complaint that worries me that I think might be from an enlarged lymph node and I want to check it out, I tend to not order a CAT scan. And actually, guidelines discourage us from using CAT scans frequently in a patient with CLL/SLL, particularly if they're not on treatment. Does every patient need a bone marrow biopsy? Certainly not for diagnosis, as I've explained. We can get away with a simple peripheral blood flow cytometry. So why would we do an invasive test? I typically, outside of clinical trials, which often require bone marrow biopsies still, I typically do not do bone marrow biopsies. I feel comfortable even in patients on treatment and following their disease response based on the regular blood draws and in the less invasive imaging modalities. Now, there are some oncologists that prefer to check a bone marrow prior to starting treatment and then reassess while patients are on therapy. So you'll see a little bit of variation in practice, but actually the guidelines have de-emphasized the importance of a bone marrow biopsy, and which I think is probably to the delight of a lot of patients out there to avoid that invasive procedure. The situations where I might think about a bone marrow biopsy would be if a patient has a low blood count, say a low red cell count or a low platelet count, and I don't necessarily think it's from the CLL. Maybe the lymphocyte count is not that high, and so I suspect something else might be going on, like an autoimmune disorder. Getting a bone marrow can tell me how much CLL is in the bone marrow and whether or not it explains why a patient's specific blood count is low. So outside of clinical trials, though, I thankfully am not having to do bone marrow biopsies very much. So what about some of these myths that I referenced? CLL is a chronic cancer, so it's one of these good cancers, right? So you got diagnosed with a good cancer, nothing to worry about. So that is wrong. The fact that the disease is labeled as chronic, it doesn't have anything to do with the prognosis, and actually just denotes the stage of cell development where the cancer event occurs, and helps us differentiate from acute leukemia, for example, which is managed very differently. What about, we're talking about the stage of where the cancer occurs. What about the overall stage of CLL? Is it important to know that? You've got, Rye staging in the United States, Binet staging that's more European. I have really de-emphasized the importance of staging in my clinic. I actually try to avoid discussing it. The reason why is these Rye stages and Binet stages and the data associated with them were developed at a time where all we had to treat CLL patients was traditional cytotoxic chemotherapy, and the outcomes were overall worse. And as Dr. Hill will talk to you about, we've got a lot of really excellent treatments available for CLL patients, more coming down the pipeline. I can't even tell you an accurate estimate for the median progression-free survival of a CLL patient that receives a Bruton's tyrosine kinase inhibitor as their first treatment, and the data goes out 7 to 8 years at this point. So that's just median progression-free survival, not even overall survival, and I can't even quote that at this time. So how could we even begin to take information from staging and give overall survival estimates? And that's what I find, unfortunately, that most patients get caught up doing is if we discuss stage, they'll go home and Google life expectancy and get very inaccurate information. So I actually try to avoid staging information. The only time I include it is, again, on clinical trials if they request it. But all the prognostic data associating with staging is outdated at this point. I try to stick to the prognostic workup that Dr. Hill is going to talk to you more about in terms of assessing, expectations. What about, I've already alluded to starting patients on treatment, yes or no, with CLL. So I've got cancer, I need treatment, of course. Well, I've already kind of answered that's wrong. And you all probably are in the audience, many of you are on active surveillance. I like to use that term, active surveillance, as opposed to just watchful waiting. That seems to be more passive, but really we're actively following whether or not a patient has reasons to treat, because although we've got great treatments, there's still overall a limited number, and we want to save them for when we need them. And as I'll show you later, there's never been a study that shows starting a treatment early at diagnosis on a CLL patient that doesn't have a reason to start treatment has led to longer life expectancy. So let's fix a problem with our treatment and not just start everyone on treatment. So what are these problems? I would say actually the most common is going to be significant cytopenias. So that's a word we use for low red cell count or low platelet count. And that's indicating that the bone marrow, the disease in the bone marrow is taking up so much space that the bone marrow can't make enough red cells or platelets. Well, if the spleen or the lymph nodes are so big that they're causing pain, that's another reason, or flu-like symptoms. So if the patient is having drenching night sweats that are recurrent and occurring for multiple weeks, not associated with an infection, or if a patient is having significant fatigue, spending half the day or more just having to rest, that's going to be, and we don't have another reason for that other than the CLL. That's going to be another indication for treatment. The fevers and the weight loss I don't see as often with CLL. I get a little more worried about high-grade lymphoma in those circumstances. And then just important in understanding what are the reasons to treat, we need to know what we don't treat. And specifically, I would highlight the elevated white count as a reason not to treat. We really are more interested in the red cell count and the platelet count. So I'm always trying to reorient my patients to focus on the red cell count and the platelet count and not so much the white count. The white count is not always reflective of how significant the disease burden is. And I've had to start patients with white counts that are low in the teens, and I've been able to actively continue surveillance on patients with white blood cell counts well into the 300s. So you want to follow those indications, those that are internationally set criteria. You might hear them referred to as the IWCLL criteria. And those are how we standardize enrollment on CLL clinical trials. And it's also how we try to standardize judging who does and does not need treatment in standard clinical practice. Here's just a complicated, what we call forest plot. That's a study that has shown that on a bunch of different clinical trials, starting treatment early never showed to improve overall survival in CLL patients. So why we continue, even with our newer patients, to just actively surveil patients that don't have a reason to treat. So another myth about patients is that CLL patients will die of their cancer. Wrong. And actually, with the treatments that we have today, you know, I've quoted that I can't even get a good grasp on an accurate long-term progression-free survival in the frontline setting yet, with many years of follow-up. I think a lot of my CLL patients will live out their normal life expectancy, and I call that a functional cure. But what we do have to watch out, and we're all more aware of in our current situation worldwide, is infections. Infections are actually the leading cause of death in CLL patients. If patients have recurrent infections, we do want to check the IgG level, because sometimes replacing with IVIG can help some CLL patients. So if you're having recurrent infections, talk to your oncologist about that. What about vaccines? A lot of discussions about vaccines these days. I would like to highlight that most CLL patients are likely going to be eligible for the COVID booster at this point, but you can have your COVID spike antibody levels tested to see if you've responded to the COVID vaccine. There's some information here about pneumococcal vaccination, which is highly encouraged. Of course, annual flu vaccine is highly encouraged. You can go for the higher dose, but that's not necessarily required. And then now we have the Shingrix vaccine for shingles, so we don't have to worry too much about any live virus vaccines as part of the normal vaccine recommendations. So for the sake of time, I won't spend too much time discussing these other common questions. But just in brief, we don't know why most patients get CLL. It's not connected with any known exposure the majority of the time. There's no family screening that's necessarily required. Only a small fraction of CLL patients will have multiple family members that also have CLL, and in those circumstances, a genetic counselor can be facilitated an evaluation there with your oncologist and a genetic counselor. And what can patients do? Really, there's just general recommendations for the population as a whole in terms of good diet and exercise. Same recommendations your cardiologist or PCP would probably give you, and not necessarily specific to CLL. There's no specific nutritional or exercise interventions for CLL in a vacuum. It's more just general health recommendations. So here's my final slide, and it's been my pleasure to give you just a brief background on the initial workup and info about the diagnosis of CLL. And I'll be happy to meet with you all soon to take any questions.